So the second talk is a co-work and a co-production of two sites. On the one hand, from our service in Geneva, where also Osman Ratip, who is also one of the international recognized experts in cardiac imaging, Markus Schweiger, head of department of the nuclear medicine department of the Technical University of Munich, and myself. So I think everybody of us knows the different imaging methods and their qualities, how to image when looking at conventional things like SPECT, echography, and newer technologies, PET-MRI, and also CT angiography. I don't want to go into the details too much because I think also there Professor Kaufmann will have some very interesting slides on that later on. And everybody of us knows more or less the properties of these technologies for imaging ischemia function, to objective, to do quantification, to have a better resolution, and to perform coronary imaging. And well, let's say the gold standard or the very known methods and validated methods are SPECT, which is independent of the operator, and cardiac echography, which is more dependent. And now the upcoming technologies, since they permit for absolute and relative quantification, are PET and MR, which were developed for cardiac imaging separately from each other. And now, since we have the integrated machines, it's clearly seductive to perform PET-MR at the same time. As already mentioned, there was a certain evolution between how to integrate PET-MR. Either you use separate machines like it's done by Philips and GE, or you by GE, or you get very close in the same time. So let's say coplanar imaging, like it's done by Philips, or you use fully integrated with all its advantages and disadvantages, which is done by Siemens. So what are the imaging targets in cardiac imaging? Well, everybody of us knows we are doing very much perfusion imaging, but we are also looking at metabolism and viability. So these two things will be the major issues of my talk. And then I will also talk a little bit on plaque imaging, angiogenesis, and gene expression if we have the time at the end. So when looking at perfusion imaging, MR with pharmacological stress is an alternative to stress echo, which has a better resolution and a higher accuracy. It is not limited by an acoustic window, and big advantage is not operator dependent. On the other hand, we have cardiac PET with full quantitative analysis, for example, here in a patient with a defect in the anteroseptal wall in perfusion, and a nice mismatch which is still viable, and so this patient may profit from intervention in this area. Another one is another advantage of the cardiac PET imaging is you can do full quantification, especially of flow reserve. Here a patient with a normal study, stress rest imaging, and a flow reserve in the three vessels which can be characterized as normal. And the problem we always have, especially in SPECT imaging, are the patients with triple vessel disease. For example, here a patient with 100% stenosis in the LAD, 85% in the circumflex, and 70% in the right coronary artery. Well, this one in the anterior, okay, we can see it, but the other ones, especially when it's a balanced ischemia, it's very difficult to quantify with SPECT. And their coronary flow reserve, fully quantitative by PET, here clearly decreased flow reserve, is showing this patient has real ischemia, and there has to be something done in him. How is typical hybrid PET-MR protocol? This is the protocol as they are doing it in Munich. The whole thing takes around about 1 hour. for, on the one hand, the different MR sequences as here. They do it with gadolinium contrast also to look at late enhancement later. They do adenosine stress and then list mode acquisitions after injection of ammonia in stress and rest. And what they found was when looking at, when comparing head-to-head the two methods, is that it's when looking at just doing just a slice average at mid-left ventricle, the correlation between PET and MR was quite good. When looking at different segments, it was not that good at all. And the impression was that MR rather underestimated the perfusion in comparison to PET. And I'm very keen to know what Philips is thinking about these findings. The same thing here, just in another diagram, rest compared to stress. In rest, both methods were quite similar, and there were just some discrepancy when looking at the stress imaging, and also when looking at the flow reserve. MR seen PET came up with higher flow reserves compared to MR imaging. So the other thing is, what do we have as new tracers in cardiac perfusion imaging? Because up to now, what is available is for those who are lucky and have a cyclotron on-site who can work with ammonia. It's quite nice. Then there's the generator-based solution using rubidium-82. But right now, there's a new flow tracer coming up, which I think already has now FDA approval in the US, which is the F18 fluopyridase, which has really great properties in terms of extraction. There, the extraction is really almost really proportional to the coronary flow in comparison to the traces we know from SPECT imaging. Here, thallium, and here, MIBI. So you really have objective quantification possibility using this new tracer based on F18. So let's look a little bit on metabolism and viability. Why is it important? Because if a coronary area is viable or not will decide whether the patient will go on with conservative treatment or versus coronary let's say replacement, or even in severe cases to heart transplantation. And when looking at how is cardiac MR performing, quantification of myocardial viability, you do gadolinium injection, and in a normal myocardium you have a fast wash in, and then with a peak, and then a fast wash out, which is normal. Infarcted myocardium, the so-called late enhancement, what we can hear on the right-hand side in a subendocardial manner. There's the wash-in is much slower, and the gadolinium rests within the infarcted myocardium, and this is the so-called late enhancement. And this is was nicely published also in Chicago prior, and correlated to the histology. Here you can see the infarction and the late enhancement of gadolinium in the same patient. When looking at perfusion, and once again, one patient who has a perfusion defect in the inferoseptal region, function thickening a little bit compromised, and delayed enhancement, which is in favor of an infarction. However, another patient also with late enhancement on MR, then fused with the PET using FDG. Here's almost a match finding. However, there is some very, very low viability still in this virtually infarcted region in PET. One other patient, which was a very interesting finding for us, was this patient with very probable anterolateral scar. However, when looking more precisely, we have this late enhancement in the apical region, however, rather very much viability. So there was a false positive of MR, and we found very good viability in this region. I think also Philip might comment on that later on. So another interesting application of PET-MR in the future might be to discriminate in special cases CAD and active sarcoidosis. Here a case of a 50-year-old female with known pulmonary sarcoidosis, known coronary artery disease, and dyspnea on exertion. So we didn't know, is this dyspnea related to sarcoidosis or is it related to active CAD? So stress-dependent ischemia. We performed first thallium SPECT, which found a fixed anteroapical defect, but we didn't know where to correlate it. MR showed same findings with late enhancement in this region, subendocardial gadolinium enhancement in this region. And however, PET did only show a very, very slight uptake. Well, was the question, is this rather inflammatory or rather hibernating myocardium? When doing the overlay, we found active pulmonary sarcoidosis, but not sarcoidosis in the lung. So active pulmonary sarcoidosis, in this case, no evidence of cardiac sarcoidosis, and CAD with anterior non-transmural scar. So we can skip this. How is our acquisition protocol when looking at the FDG? And what we are doing is we inject FDG in a low carbohydrate diet. Then set up, the patient will be positioned on the machine. The machine is calibrated. Then we do all the MR different sequences. Then we do and PET. Afterwards, we are doing MR perfusion imaging, gadolinium rest perfusion, gadolinium. We wait 10 minutes, and then we look at the late gadolinium enhancement, and finally then at the PET. Those are the different or the precise MR series, MR sequences, what we did, and also there are many sequences, and once again, need for speed. I think there is some potential for improvement. Do we when combining these two methods, do we really need all these sequences in order to give an answer? And what was interesting, we did an evaluation studies on 20 patients, and we looked in dysfunctional segments, and we characterized any FDG uptake more than 50% of the maximum viable, and the other, which were inferior, were characterized not as viable. When looking at late gadolinium enhancement, less than 25%, it was characterized as viable. 25 to 75 was characterized as undeterminate, and more of 75% LGE in the segment was characterized as non-viable. And when looking at the comparing PET and MR in these different settings, looking at 68 segments with akinetic cine MR, red is always viability in PET, in FDG PET, and blue is always viability in, red is scar, blue is viable tissue in PET, and using the two methods we could decrease significantly the number of undefined, but however when looking at undefined, coronary MR undefined in PET non-viable regions, however there was significant numbers of undefined in MR. So just 2 words on plug imaging. Everybody of us knows the cascade from a normal cardiac vessel to via a remodeled vessel to a stenotic vessel, and which is creating vulnerable plugs, which are interesting for us for imaging in order to predict coronary events by different methods. And here's one of the first publications on this issue by our colleagues in Munich, by the group of Markus Schweiger, in a patient with visibly a normal coronary angiography. They did now MR angiography, and in this case really it was a normal finding, despite here in this case using a special sequence. The RCA was still normal. However, when using a DE-MRI sequence, they could show that there was vessel wall abnormality. And when fusing the same thing then with FDG PET, also there was FDG activity in this region, clearly showing inflammatory activity and predicting for a possible coronary event later on. Some words on angiogenesis markers. There also here the cascade, you have myocardial ischemic injury, then angiogenesis is started, collagen is built, cell activation is done, and there those activated cells are expressing integrins, and that is, integrin are the targets for the imaging of myocardial repair. What they did also, this was from the Munich group, they induced in mice by the ligation of the left coronary artery, they induced a myocardial infarct and did analysis for clearly in histology and also in with integrin imaging. Here one very nice of these cases, with here the scar in the apical region. When looking at the perfusion with ammonia PET, you can see here the scar, and when using RGD as an integrin marker, you can see the induced cell repair. So there are still viable cells which can be repaired, and this might also be a prognostic factor doing this imaging. Finally, some words on gene expression. This is quite very complicated there. We're just at the beginning when using intra-coronary cardiosphere-derived cell transplantation. Just some images on that, which were published in the Lancet with here one case with late gadolinium enhancement in this case, and then their work using for MR iron particles to emerge that, and on the other hand, which are transported partial with natrium iodide, iron particles, and using iodine 124 traces, which is included into the cell by the natrium iodide symporter, what we all know, into the donor cells, and then we can image the integration of these transplanted cells in heart tissue, as we can see here how it got there in at the beginning and then as it's going out slowly. So in conclusion, multimodality imaging provides very attractive tools for translational research on the one hand. Hybrid PET-MR can consolidate the diagnostic finds of both modalities and thus reduce uncertainty, as it was also in PET-CT in oncology. Quantitative data analysis will really bring a refinement of already established parameters such as coronary flow reserve, SUV measurements, and others. Molecular imaging represents a great opportunity to address important therapeutic targets such as plug stability and ventricular remodeling, which has important prognostic impact. And numerous molecular traces are just now being developed, but they require still regulatory acceptance and clinical validation, and they were just at the beginning. With that, I'd like to acknowledge on one hand Professor Ratib from Geneva and Professor Schweiger from Munich. And with that, I'd like to thank you for your attention once again.